Thank you for the nice introduction. I told you to make it short, but you haven't. It seems like between all of you and the lunch, it's only me. So, but I've been given 20 minutes, so I will use those 20 minutes. And the topic which I've been given is atrial fibrillation. So we'll try to make sure that you don't start getting atrial fibrillation while waiting for the lunch. Okay, so no disclosures for me. So these are the objectives of my talk. So I'll talk about diagnosis and clinical presentation of atrial fibrillation. We'll mostly focus today's talk on ESC guidelines. Then we'll talk about CC to ABC to care. I'm sure some of you already aware what does that mean. The often talked about rate versus rhythm control strategy, and then management of atrial fibrillation. So those of you who are not aware, very recently, less than a month, there was in Emirates Cardiac Society meeting in London. There was 2024 guidelines have come up. I would suggest to read these guidelines, whoever is interested in atrial fibrillation. So you can see on 30th of August. So my talk mostly would be from this. So we move from ABC to care. So what the next thing which we're going to talk about is So from ABC, it was from CC, then ABC, and then now to care. So what's care? Care is comorbidities and risk factor management, A for avoid stroke and thromboembolism, R for reduce symptom and rate control, and E for evaluation and dynamic reassessment. Talking about the global prevalence of atrial fibrillation. So luckily, our part of the world, if you could see that this is less than 600 per 100,000 population. So our part of the world is actually green. So not much prevalence of atrial fibrillation, but the prevalence of atrial fibrillation is increasing with age and increasing as we go by in the years, decades by decades. So how do we present this? How do the AF present? So this is from the last 2020 guidelines. As you could see that it could be asymptomatic. Patients have a high mortality. Patients might have a stroke. So it's 20 to 30% of ischemic strokes are related to atrial fibrillation. You might have a heart failure. You might have cognitive decline, depression, impaired quality of life. So lots of risk factors, lots of reasons why AF is important. This is a new one they have come up with now in 2024. Now they are dividing these AF in clinical presentation more easier to think about from symptom point of view. These are the symptoms they can come up with. These are the adverse outcomes they can come up with, and these are the healthcare and society related factors. So obviously now there's one more thing which is very important here. So look at that, the doubling of atrial fibrillation from 2010 to 2060. This is the predicted. We always heard that lifetime risk of 1 in 5, that's going to 1 in 3. So all of us, 1 in 3 risk of atrial fibrillation. So what's the diagnostic criteria for atrial fibrillation? It's simple. You need either a 12-lead ECG or multiple leads or single-lead ECG to establish the diagnosis of clinical AF, and you commence risk stratification and treatment. This is 1A recommendation by 2024. And you also you evaluate the impact of AF on you. So not only you just diagnose it, you see what AF is causing to you. How do you diagnose it? This is from 2020 guidelines. There are several methods, as you can see. Have different sensitivities and specificities. Starting from the pulse taking, you have ambulatory blood pressure, you have lots of smart devices, you have watches. There are several methods where you can diagnose the ECG. This is more recent, 2024. Again, on the similar lines, they're telling you there are some ECG-based methods and there are some non-ECG-based methods. There are some non-diagnostic methods like pulse palpation, you have oscillometry, you have PPG, you have tracing. So there are several ways to diagnose atrial fibrillation. How do we then temporally define atrial fibrillation of different kinds? This is very important. So first of all, it's a first diagnosed atrial fibrillation, easy, because this is the first time we have encountered it. Next is paroxysmal atrial fibrillation, which comes and goes, but within 7 days. Persistent is when you go beyond 7 days, you still have this atrial fibrillation going on. Permanent is when you have done everything what you could do to maintain the rhythm back to sinus rhythm, but you were not able to achieve it. So this is when you call it as a persistent atrial fibrillation. These definitions are very important because keep in mind that I'll be talking about their management in the next few slides as well. So remember, this used to have this terminology of lone AF. AF almost never comes alone. Lone AF, the definition is almost going out of the window now. It's no more in the literature. There are some non-modifiable risk factors which you can see regarding the age, the male gender, ethnicity, height, things like this. And then there are some modifiables, so a lot of modifiable risk factors. You can say we have divided them into, you have things like vagal and adrenergic stimuli, like alcohol and caffeine. You have atrial stretch with heart failure or HFpEF. You have inflammation like acute illness or sepsis, or maybe you might be having inflammation while waiting for the lunch, or endothelial dysfunction. So there are several ways that how AF can come. So this is what I was talking about. So we started with CC, which used to be confirmed AF and characterized AF. They then moved into the last guidelines to ABC to make it more simple. But then they have now realized that actually the most important thing is care, it's comorbidities and risk factor. It's just the other way around. So they're just musical chair, like moving from one to other. But mainly it tells you that now we are talking more about comorbidities and risk factor management, and then talking about avoiding stroke, reducing symptoms, and evaluation again. So now let's take them one by one. So this is what I just showed you before. Let's take them in more detail about C. What is C? C is comorbidities and risk factor management. As you can see that there is hypertension, which is very common. My colleague, Dr. Niaz, just talked about it. So it's a class 1 recommendation that you reduce the blood pressure. You try to manage the heart failure with diuretics or appropriate medical therapy, including SGLT2 inhibitors. For overweight or obese patients, you do weight loss. For OSA, very important, you manage the OSA and you avoid reducing the alcohol or avoid alcohol. And you also have this exercise capacity and this. So this is all comorbidities. So you start with these. You find out what are the risk factors already, what are the comorbidities which you need to monitor. You then move on. Okay, so going more in detail about the key targets. So talking about hypertension, for instance, so this is the level 120 to 129 and 70 to 79. Talking about heart failure, you optimize with diuretics and all the other SGLT2 inhibitors and all these class 1 drugs. For diabetes, again, the class 1 is this: obesity, sleep apnea, physical activity, alcohol intake. We just talked about in the previous slide. So how important it is to monitor all these risk factors and manage them. What's A? Avoid stroke and thromboembolism. Most of you are aware about it. We have heard about it. So let's take them more in detail. So what we're talking about, that we risk stratify the patients, and I'll talk about this new Chad's Way score. Start oral anticoagulation class 1, and let's go in more detail in the next slide. Let's skip that slide. So we all heard of Chad's West score. Those of you who are old enough, then like near my age or maybe older than me, are aware that Chad's 2 score used to be there, and then it comes Chad's West score. I always had any issues with Chad's West score because when they were a sex category, which we were not sure whether we give a point or we don't give a point. So now this is gone. So no more Chad's West score. It's Chad's VA score. Sex category is out. The rest remains the same. Almost the same as Chad's West score before. Let's talk about in more detail in terms of ESC guidelines. Like we said earlier in the previous guidelines as well. So DOACs are recommended in preference to VKAs. That's a 1A recommendation, except 2 conditions only. You have a moderate to severe mitral stenosis, or you have a mechanical heart valve problems. Now, target of INR 2 to 3 is recommended for those who you want to give VKA, so you can give it. And switching to DOAC is recommended only for those patients who are not maintaining the TTR as more than 70%. So if you are less TTR, less than 70%, TTR is time to therapeutic range, then yes, you can switch them to DOAC. What more important also is that not only the DOAC is important, they're also saying that maintaining VKA treatment rather than switching to DOAC may be considered in patients more than 75 who have a stable therapeutic VKA with polypharmacy to prevent excessive bleeding risk. So that's another indication. Now, a reduced dose of DOAC is not recommended unless patients meet DOAC specific criteria. So generally we think that, okay, well, we have a patient who is elderly, maybe high bleeding risk. Unless the dose specific DOACs you want to pick, you don't need to reduce the dose just because you want to reduce the risk of bleed. Adding antiplatelet treatment, remember, to oral anticoagulation is not generally recommended. Just because you have a patient with AF and had a stroke or any other problems and you just want to give another antiplatelet, it will increase the risk of bleed with no further advantage. So lastly, that if you have a patient where you could not give VKA, you could not give DOAC for whatever reason, hemorrhagic stroke or bleeding risk or whatever risk, then you can go for this percutaneous LA occlusions. They are devices which you can put them to avoid having any complications through AF. So that was the assessing the risk and cardiovascular risk with the CHAS VA2 score. Okay, so essentially this what is telling you that you take a medical history to determine the bleeding risk score. So what about the bleeding risk score? So again, the Hasbled scores are out. No more Hasbled scores. They now more talk about modifiable, non-modifiable risk factors. So look at the top one, what it says. So it says comprehensive medical history you have taken. It's a class 1 to determine the bleeding risk factors. Do not use bleeding risk scores to decide or starting or withdrawing oral anticoagulants. What it's telling you that scores are only a guide to tell you that maybe they have a high risk of bleed, okay? But you should not use them to decide to start or withdraw oral anticoagulation. Now, how do you manage modifiable bleeding risk factors? These are different things. Like, for instance, you have a hypertensive patient, you optimize their blood pressure control. If you have somebody who is on NSAIDs, you might find alternatives. If somebody is on all antiplatelets, we'll talk about in the next few slides, that you do not give antiplatelets. We just said that you do not give antiplatelet drugs unless there is a good indication. For alcohol intake, you reduce their alcohol intake. If you have an unstable INR, obviously you try to keep the INR between 2 to 3 and TTR more than 70%. If there is a reason you can't do that, you switch it to DOAC. So what are the potentially modifiable risk factors which we're talking about? So these are the potentially modifiable. So like anemia, reduced platelet count, renal impairment, risk of falls, diabetes, CCF. These are all the potentially modifiable risk factors. And then there are some non-modifiable bleeding risk factors like age, previous major bleeding, genetic factors, malignancy. So essentially, rather than just stressing on Hasbled score or any other scores, no bleeding score is good. Look at the risk factors of your bleeding, try to minimize those bleeding risk factors, and carry on with the treatment which patient deserves for atrial fibrillation. So this is just a summary in terms of bleeding. You can say the 1B indication is assessment and management of modified bleeding risk factor is recommended for patients who are eligible, okay, as a shared decision making. And use of bleeding risk scores, this is very important. This is new. To decide on starting or withdrawing is not recommended with AF to avoid underuse of anticoagulation, because you will start underusing anticoagulation. Let's move on to next, the RE. So we talked about C, we talked about A, now this is R and E. So reduce the symptoms by rhythm and rate control, and E, the evaluation. So now the famous thing about rate and rhythm control, we always kind of argue about this. So first diagnosed atrial fibrillation, easy. Hemodynamically stable patients, you go for unstable patients, you go for electric cardioversion. So if it's not stable, you go for rate control. If the patient is stable, then you go for rate control. With rate control, you have an option if you have good ejection fraction, beta blocker or digoxin. If you have LV ejection fraction not good, then you can go for beta blocker, digoxin, diltiazem. Sorry, that's the other way around. So good with this, and if not good, beta blocker or digoxin. Or you can try the combination, and then cardioversion of symptomatic persistent atrial fibrillation. What do you do with the paroxysmal atrial fibrillation? So for paroxysmal atrial fibrillation, again, same thing as AF care, okay? You rate control target is rate less than 110. If the patient has got ejection fraction, which is good, okay? So you have beta blockers, again, the same thing as calcium channel blockers or combination. Or if it's not good, you have these options. What do you do next? So shared decision making and looking at antiarrhythmic drugs. You have class 1A drug of amiodarone if I have a poor ejection fraction. For midref, you have amiodarone or dronedarone. If you have a very normal heart with no ejection with good ejection fraction, you have dronedarone, flecainide, or propafenone. The other drugs are sotalol. If you continue to have recurrence of AF symptoms after that, again go back on shared decision making. You can see that how many times they keep using this shared decision making, that it has to be shared with the patient and the physician. If you failed antiarrhythmic therapy, you go for catheter ablation. You also have options if you failed in this, redo surgical or antiarrhythmic therapies as before. So what about persistent atrial fibrillation? So when we're talking about then the patients have done everything, we have tried all the antiarrhythmic drugs, but actually they are still in atrial fibrillation. So you start with the same thing. If they are hemodynamically unstable, you go for electric cardioversion. If they have good ejection fraction, bad ejection fraction, you go for amiodarone. Mid-ref, this is all repeated, same as before. The only difference with persistent atrial fibrillation, you have different more options. You have endoscopic, hybrid or surgical ablation, and you have rate control at the end, obviously, because now you have used all the resources to convert them into sinus rhythm. You don't have any option. They are persistent in atrial fibrillation. You just rely on rate control therapy. So this is permanent atrial fibrillation. Patient with permanent fibrillation, same all these things. I will take you to the next. When you get to the rate control, you can see that you have either options again of rate control of beta blocker digoxin or combination of these things. Once it's not working, you continue to review and follow up as per AF care and intensify rate control under observation. So when we decided the patient is for atrial fibrillation, for cardioversion, okay, so you again see whether the patient is hemodynamically unstable. You have decided already patient is unstable and he's for electric cardioversion. You don't have to wait for, obviously, for anticoagulation. So you do the emergency electric cardioversion, you check their OX status, oral anticoagulation status, and proceed, okay, with electric cardioversion. Let's say you do have time, patient is stable, you check their OX status. So if they're already on OX, it should be minimum 3 weeks. Okay, if they are not on OX, oral anticoagulation, you start them, okay, not already on OX, you check that whether the cardioversion cannot wait or can wait. If can wait, then you can start them on anticoagulation and wait for 3 weeks. If it cannot wait, you start the DOACs, okay, and proceed with cardioversion. And I'll talk about the next slide. What do you do next? So once the patient is on, so we have gone now here. So once the patient is either already, you started initiation of DOAC, okay, and you again went with cardioversion, or you already had to go for cardioversion straight, you decide on continuing oral anticoagulation post-cardioversion for probably 4 weeks. If you have not started, if you could have waited for the patients, you can go for pharmacological or electric cardioversion once you have started them on for 3 weeks. Let's say that didn't work. You have already gone for therapeutic anticoagulation. You started electric cardioversion. Then you decide whether the current symptoms, episode duration was more than 24 hours or less than 24 hours. So the AF, if less than 24 hours, you go for this. If AF more than 24 hours, you have to go for TOE guided cardioversion. This is when we're talking about when you have waited a long time and the patient has already been on anticoagulation and the patient has been stable, and you could wait for a bit for this patient for a few weeks, okay? One of the last slides I have, often we ask this question to our cardiology colleagues, okay, if you take a picture of this slide, I don't think so you need to go and ask these cardiologists that whether they need to, so the bottom line is that when the patient is already on VK or OAC, okay, what do we do about these antiplatelets? So the top thing, what is that? DOACs rather than VK are preferable. So DOACs better than VKs, that's for sure, okay? Next thing, use the appropriate DOAC dose. A reduced dose is not recommended unless you have the patient meets DOAC specific criteria. We already mentioned that as well. Okay. The next thing is very important here is that clopidogrel is the preferred among those when combining with any oral anticoagulant. So aspirin is not a good one. Actually, if you are going to combine anything, antiplatelet, it has to be the clopidogrel. And these are the guidelines in terms of what do you do in terms of from weak if you have an ACS undergoing PCI, if you have high ischemic risk, ACS with medically managed, chronic coronary syndrome, uncomplicated, chronic coronary syndrome, high ischemic risk, and stable coronary syndrome. As you could see that if it's stable and it's chronic coronary syndrome, you don't need antiplatelets. There are only few indications where you do need antiplatelets, especially the triple therapy, sometimes only up to 1 week, in the high risk, maybe up to 1 month, okay? Okay, I think probably I just need 1 minute. This is the last slide. Thank you. So if you could see that for so ACS who are medically managed, again, you can see just clopidogrel up to 6 months, okay? So the bottom line for this slide is that DOACs, if they're required, preferred over VKA. If you're going to use any antiplatelet, use at the minimum. If you are going to choose among aspirin and clopidogrel or ticagrelol, you choose clopidogrel. When you choose clopidogrel, be careful of why you're using it, because if it's stable, chronic, you don't need clopidogrel. You're just okay with oral anticoagulation. But in some instances, you might need it for a week or for 1 month or even longer as well in some cases. I'll leave you with this next slide. Last slide. Yeah. So again, I very like this if you want to have a picture of this as well. This beautifully tells you that if you are on DOAC, how do you actually monitor the DOAC? So look at this. So this is the renal profile. So depending on your EGFR, how often you need to do these tests. This is actually the HB, and depending on your bleeding scores as well, how often you need to monitor that. And this is for the liver disease. So if you have no liver disease, or if you have child ABDC, how often you have to monitor these levels as well. These are my references. Thank you.